Thank you, Sarah, and thank you to Karen and Dale for this great learning opportunity. I've had such a good time and really am gaining a lot. So this talk is going to be about mainstreaming, and by that I kind of mean that, you know, there are about, in my figuring, there are at least 300 million major medical decisions made in the US every year. And by mainstreaming, I mean that most of those decisions are done with shared decision making. So most doctors, most patients, most patient-centered or preference-sensitive care decisions are made with the benefit of the patient being informed and involved. Al Malleh uses the term avoidable ignorance, that so many of these decisions are made with the patient in the dark about what their options are and what the benefits and risks are for those options. We want to change that, and we want to get it into the mainstream of medicine. So I'm from Idaho. So mainstream for us isn't mainstreaming of education, it's mainstreaming in the rivers. And so what we're hearing here is that there are a number of tributaries, like Dartmouth-Hitchcock, where we're kind of getting to the mainstream of shared decision making, or at least we're getting a good taste of it in these isolated areas that are contributing. Still, we're also hearing around the tables that there's a lot of barriers that are keeping people from getting into the mainstream. And actually, I've also heard that there are some disasters that happen. So when you don't have the right tools or you're not fully prepared, really bad things can happen with shared decision making. And the guy in the front of this boat, that's me. I'm going over lava falls in the Grand Canyon, and the guy with the oars, a second later, is no longer in the boat. So, you know, I want you to help avoid things like that as we move along and try to get into the mainstream. And in rafting, the mainstream is kind of that sweet spot in the middle of the river where you find the current, and with the least amount of energy, you're able to guide the boat the fastest and without any risks. And that's really what we're after in shared decision making. So this is Healthwise. We're in Boise, Idaho, a little piece of the Rocky Mountains in the background. We're a not-for-profit organization. I founded it in 1975, so it's been a dead-end job ever since. And Healthwise delivers its information. Our mission is to help people make better health decisions. It's been our mission since 1975. And we do that by delivering information to clients. So we don't really have a consumer health website that everybody comes to. Instead, we license our information to health websites, to health plans. In fact, you know, of the 10 largest health plans in the US, all 10 license our information. And for hundreds of hospitals, including Dartmouth-Hitchcock and many other hospitals you're familiar with, if you go inside their information, you're likely to find information written and developed, created in Boise, Idaho. So you may be using our stuff and not know it. There's always a logo at the bottom, but that's it. So just for curiosity, you may not know that you're using it, but how many of you know that your organization is using Healthwise information? So a good party, great. Among the other information that we've developed, we have 162 patient decision aids. So do I need this test? Do I need this drug? Do I need this surgery? Lots of other things included. So if you add it up, it's a little more than 162, but that's just because there's some overlap among the various things. And so we're trying to develop a fairly mainstream approach to getting these decision aids and shared decision making done across a pretty broad sector of the healthcare system. So over the years, we count the number of times people have come to our information. Last year, we hit the magic number of 1 billion. So the billionth time somebody has used Healthwise information. Of those billion times, about 8 million times a year, people come to the shared decision making topics. Doesn't mean they get all the way through it, but they at least access the shared decision-making topics. So I think of the issue of shared decision-making as really having two goals. The first goal is what I call IX. It's getting the information to the patient at the right time, the right information, the right place. Everybody knows what RX stands for? Okay, RX, it's from the Latin. The R represents a recipe. And the X, I don't know if you know it, represents Jupiter, the god Jupiter. So it's sort of like, here's your recipe from the gods, take it and pray that it helps. An IX is an information prescription. So it's take this information, read it, understand it, and pray to the gods that it helps. So that's a good part of it. And so at your tables, you should find something that looks like a list of decision aids. Looks like this. So what I want you to do is to look over the list. If there's anything on this list that you would have interest in seeing as if you're a patient, then take out your business card and just write on the front of your business card the number that's associated with that decision point. We're going to put your business cards on a piece of paper. We're going to take a picture of it, send it to my executive assistant, and she's going to use the program we demonstrated last night to send you all HIPAA-compliant, secure messages that will give you access to that decision aid as if you're a patient. Now, we'll collect these later on, but I'll just make a little note related to Sarah's topic. If you're interested in a list of what we and the Informed Medical Decision Foundation have recently put together in terms of preference-sensitive conditions or preference-sensitive decisions, if you write on the back of your business card, list, we will separately, without HIPAA, send you that list. So does that make sense? Okay. So this is what it would look like on mine, number 37, and then turn that in if you're interested. Okay, so the first goal is getting that information to the patient, and that's what we want to do. The second goal in shared decision making is getting the patient's response to that decision aid back into the clinical record and into view of the clinician. And that's sort of a new thing, and it's a new thing that technology is allowing us to do. So that's really a key thing. And it's all around the voice of the patient, and what I have here is a little video of a Boise, Idaho patient who's had some fairly serious health problems, and she has become sort of a national spokesman for the voice of the patient she does a lot of work with the Office of the National Coordinator for HIT, and here is Peggy Jo.
That even though the patient in our system in America is kind of the gatekeeper of the information, there's no documentation of the patient's voice within these medical records. And that's really, it can be really demeaning and demoralizing, and I think very unhelpful in helping physicians figure out what's going on in your case. I'm the only one who knows what it's like to have the brain bleed inside my body. I know how I feel in chemotherapy. I know what it was like to be in the coma. I know what it's like to have the hemangiomas. So I have really valuable information that nobody else has. And there's no place in our medical records that that voice is actually documented. And that's really frustrating to me. Because I want to be a part of the group. I want to be inside the circle. I want to be talking about it. I want to figure it out. I want to live.
Okay. No matter who you are, every patient feels like this at some point. They're sick, they're frightened, they're intimidated by the medical system. And just to make this point, I want to talk with you about a recent conversation with a friend of mine whose name isn't really Pam, but she's given me permission to tell her story, just not to connect her to the name. She is a physician. Not only that, she is a national physician leader in quality. And Pam has done a really good job over the years of training her mother training her mother how to be an active patient, how to prepare for every doctor visit, how to write down her questions, how to really get her questions answered in the clinic. She's done a really good job. This story is not about her mother, it's about Pam. So Pam had what she described to me as, and I'm not a clinician, craniofacial surgery. Not sure what she had done, but she had a bad experience. The surgery went well. 2 days later, she was just shocked by the look in the mirror, that her face had swollen up so much. 5 days later, her eyes were blood red. She couldn't close her eyelids. She was just scared to death. But she didn't want to call her doctor. Go figure. So guess what happened? Mom stepped in. Her mother called the doctor, set up the appointment, took Pam to the doctor's office, got the issue resolved, and everything turned out just fine. But it just shows, everything's fine, except she still has that memory of being completely afraid, completely intimidated, and not knowing what to do. It happens to all of us. We have to find ways to make this patient interaction with the doctor as easy and inviting and acceptable as we possibly can. And part of that is making it an expectation that they're involved in the decision and that they're expected to give their response back to the doctor, and the doctor is expected to look at it because it's in the record. So it's all key part of that. So I want you to just take a moment at your tables to think of a similar experience, somebody you know, maybe yourself, that has had that kind of a significant event and has been, for whatever reason, not able to get their questions answered, to get clarity, to get out of the dark, to become educated about their decision. So what I want to go to is just back to this and the definition that I said of mainstreaming, where most doctors, for most patients, for most preference-sensitive conditions, are doing shared decision-making in a way. And what I want to ask you is, how many know the 3 most important rules in real estate? Right, location. What do you think it is in medical care? I think it's workflow, workflow, workflow. If you can't put it in the routine workflow of the clinic, it's not going to happen. If you can't put it in the routine workflow of the patient, the think process of the patient, it's not likely to happen. We have to find ways to make it. So I want to ask you, Elliot talked about skating to where the puck is going to be, and he was using a 5-year timeline. I want to ask you, how many of you really think that in 5 years, shared decision-making will be routinely used across the U.S. for most doctors, most patients, and most most preference-sensitive decisions? A couple, all right. Well, that's a pretty optimistic group. Okay. How many of you believe that it should be? Okay. Well, I think that's most of you. So what it's going to take is us to build an infrastructure, a workflow, and to recognize the source of truth that comes from the voice of the patient, and that is a critical part of doing delivery of high-quality care. So here's the answer. I'm from the government. I'm here to help you. How many really embrace that, But in fact, in this case, it may be true, because the card the government is bringing in this country is something called meaningful use. And for those of you who don't know what that is, as part of our big Economic Recovery Act, not the Affordable Care Act, but in 2009, we passed something called the HITECH Act that provided $22 billion to reimburse clinicians and hospitals for their electronic medical records. But there was a hitch. They had to demonstrate, quote unquote, meaningful use in order to get their money. And CMS, the Centers for Medicare and Medicaid, were charged with defining what meaningful use was. And that is really a ticket to carry shared decision-making into the mainstream of at least US medicine. So the meaningful use rules have come out sort of in 3 stages. 2011, the first set went in. 2013, we're going to get an announcement of that in September of this year. And 2015 will probably be in September of next year. We'll get what the rules will be for 2015. So Meaningful Use 1 was all about infrastructure. Electronic medical records, if you were going to get reimbursed for them, had to have the ability, and I'm just talking about the patient-centered aspects of these rules. These rules were pretty extensive. They had a lot of aspects to them, but from a patient's point of view, the patient had to have access to their records on request. The EMR, the electronic medical record system, had to be able to deliver that. They had to be able to deliver what they called patient-specific educational resources, which means for each patient, for their diagnosis, for their moment in care, they had to be sent information related to that, or at least the infrastructure had to be there in Meaningful Use 1 to be able to do that. They had to have the ability for the system to give reminders. Now in this country, for years, if you've had a dog or a cat, your veterinarian has sent you reminders of when they need checkups, but it hasn't happened very often in the mainstream of medicine. When Meaningful Use 1 goes into effect, or it's in effect, you had to have the ability to do those reminders in your electronic medical record. And you had to be able to do after-visit summaries. So all of that was the infrastructure necessary to do it. Meaningful Use 2, which isn't out, so I'm only guessing, but it's a good guess because we know what the recommendations were and we know what most of the comments were about the recommendations, really said it's not just the infrastructure, but patients actually have to use it. They have to either view it, download it, or transmit it to somebody else. So, and there was the thing that at least 10% of your patients had to do that. All right, why is that important? Because if you have to show that for 10% of your patients, you have to create a workflow to make it happen. It has to be part of the routine. 10% would completely disrupt your practice if you had to do this on a haphazard basis. So the EMRs, the hospitals, the clinics will need to, if my prediction is right about this 10% figure being included this September, they'll have about a year to put that into place, and it will be a pretty major shift. Nothing so far relates to specifically to shared decision-making, although if you talk about patient-specific educational resource, there's nothing more patient-specific and educational as a patient decision aid, but it's not specifically named in these rules. So what about Meaningful Use 3? I can tell you that I have some inside information. And that we're working really closely with the Office of the National Coordinator for HIT and their committees to try, and they're already working on what will go into Meaningful Use 3. And Dartmouth-Hitchcock and Dartmouth University are also involved in helping the Office of the National Coordinator figure out what can be done and what should be done in Meaningful Use 3. So we think that decision aids are going to make an appearance there in a big way. And one thing that we do is that the second part of what's important about shared decision making, I think, will be part of the requirements for meaningful use. That you'll have to be able to not only send out decision aids, but get the patient's response to those decision aids back into the clinical record. We think that's going to be a requirement. We think that there will have to be alerts to the clinician that flag when there's a preference-sensitive condition or decision that the patient is facing. That would be automatically flagged by the computer system. We think that there will be a list of some number of preference-sensitive decisions that go on that flag list. And here's, if you had written a list on the back of your business card and you turn that in, we'll send you the list we're proposing that we've worked with the Informed Medical Decisions Foundation to help create, but it's now out for other people to comment on. And I've asked several people who are particularly involved in mental health if they would look at that list and make sure we've covered those areas as well as we should. There'll be plenty of comment time for these things, but we're trying to put in place the idea that the list shouldn't be a list of 10 or 20 things. It should be a big list, because if you expect a patient to wait until they're sick and vulnerable and scared to learn how to use a new tool, you've waited too long. You have to start earlier with patients. You have to build it into the patient's culture and the patient's experience to use shared decision making if you want them to be able to use it well at the time they really need it late in the treatment process. And we're hoping that there'll have to be something like 10%, pretty minimal requirement, 10% or a 90% defect rate. You call a defect every time there's a preference-sensitive decision that's made without a shared decision-making. That's a defect. Well, we think that at least 10% of those decisions should be made with a decision aid. And we think that that will require some form of certification of decision aids. So that's something that's been mentioned, talked about a lot. We've not really moved forward, but the IPDA standards are a good base, and there are a lot of people working on it, and we think we'll get there. Again, this is Meaningful Use 3 to go into effect in 2015. So I'm going to wrap up here. It's really back to the idea of workflow and mainstreaming. So my idea is that there is a sweet spot for shared decision making in the middle of this healthcare river, and that it really is involved with workflow. And we have to make it easy for the patient and the clinician to get into that sweet spot. And it's quite possible. So if you believe that, as I do, that the patient is the greatest untapped resource in healthcare, and if you believe, as I do, that shared decision making may be the best way to tap that resource, then I hope you will engage with us and others in advocating for these meaningful use rules that we think will really make a difference and bring this into the mainstream, at least of US medicine. And that's all I have. Thank you.